Here and now we are going to be talking about hip osteoarthritis. This is an extremely common condition. You should know everything about this condition from identification and all the way down to all of your treatment options. So going through our quick summary, what do we see? Number one, degeneration, wear and tear of the articular cartilage. That's what the name means, osteoarthritis, bone joint arthritis, okay? Narrowing of joint space, sclerosis, hardening of the bone around the surfaces. Potentially, you can see reactive sclerosis and subchondral cysts, but these are more radiographic findings. What we need to realize is how this process actually develops. So to start with, usually what happens is there is potentially genetic predisposition, but before we get there, you get little micro tears that take place, these little fibrillations where loose fibers start to break loose. Then the cartilage starts to fragment a little bit. The chondrocytes attempt to rebuild. And when they rebuild, they don't build quite the same type of cartilage back. It's a scar tissue form of cartilage. And then the underlying bone eventually becomes exposed and the bone rubs and results in reactive sclerosis, subchondral cysts, osteophyte formation, and all that stuff that I mentioned before. So prevalence, who gets this? This is extremely common for the hip. In fact, in most cases, any weight-bearing joint, hips and knees typically, and lumbar spine as well. Couple of key things to realize, approximately 7% of the population is going to have this. Peak incidence starts in your 60s. Although if you have a genetic predisposition in your family, I've seen it in 50s and 40s where people have to get hip joint replacements as well. Oftentimes they may have a congenital hip dysplasia from birth that could also be associated with this condition. So risk factors are prior trauma or repetitive stress. And it is clear in the literature a body mass index over 32 is associated with a 2 to 3 times increase in the rate of hip joint replacements. So your weight does have an additive effect over time in these conditions. If you have excessive physical load in sports and in labor, one example I can give from one patient was a martial artist. He also did filming for like stunt double for a lot of movies and everything as well, as we see around the lower mainland here where I'm practicing. And he would always plant on his left and then use that to kick around and do his pivots for his kicks. Well, he had substantial DJD into his early 40s already because of that one biased movement pattern that he actually had. Genetics, endocrine disorders can be there like acromegaly. Diabetes may increase your rate as well. Again, just another reason for us to promote good eating habits for our patients. Hyperparathyroidism, metabolic disorders can be there. Wilson's disease, your iron disorders as well. Nephritic disorders can be there. Avascular necrosis may be correlated potentially. It could be a cause of the degeneration, or it could be a separate condition itself. And leg calvé-Perths in kids, or a skiffy even potentially as well. So insidious, or I might even say gradual onset of achy knee, not knee, well, it could be knee, but we'll say hip pain to start, but often into the groin, into the lateral side of the hip, maybe into the buttock and thigh, possibly down into the knee. Morning stiffness, that usually takes about 20 to 30 minutes to warm up. Pain is better with rest or mild activity as you start to loosen it up, but worse with excessive activity. If the person does too much in the day, it actually winds up making them feel worse at the end of the day. In severe cases, they may note some popping and snapping, crepitus taking place there. And it is repeatable popping and snapping. So don't get tricked that it's like a little cavitation, or get tricked with like a snapping hip syndrome where you can actually see it or feel it snapping over. It's usually going to feel deep inside the joint. So on inspection, you may notice an altered gait, an antalgic gait, where they're going to be walking with a limp on the affected side. It's not bilateral, which it's usually unilateral, but can be bilateral. Palpation is usually going to be within normal limits, except you might notice a little bit of muscle tightness and spasm in the area around the glutes, hip flexors, as they're trying to stabilize that area a little bit, take some more of that force into the muscle, not so much through the joint. But more often than not, you are going to see a decrease in range of motion, especially if you see crepitus. This is a pathognomonic sign, almost 100% indicating that you have the DJD of the hip. Neurovascular screen should be within normal limits. There should not be vascular or neuro changes in these patients. Differential diagnosis, transient hip synovitis, shouldn't see the crepitus. Usually a younger person is where you're going to see this. Septic arthritis, look for that fever, swelling. You can't see it, but a gradual onset that progresses relatively rapidly. We'll have a separate video on that as well. Visceral pain referral pattern from the abdomen, typically kidneys, maybe bladder, something like that. Lower intestines, possibly, but that's going to look more like a visceral issue. Trochanteric bursitis, you should be able to push and cause pain around the greater trochanter to see that aggravate the symptoms. Gout and rheumatoid arthritis, gout is a little bit rare in this area, so it wouldn't be the first thing I would look for. And then rheumatoid arthritis, again, you're looking for more bilateral symptoms with that, right? And they probably know that they have rheumatoid arthritis already. And the hip is not the most common location for it as well. All right, what else do we see? Diagnosis on X-ray. You are looking for 4 key findings, and this is the same for osteoarthritis anywhere in the body. So if you remember this, you will have it correct for arthritis anywhere. The first thing you get is non-uniform joint space loss. Please remember that one. Non-uniform joint space loss. Typically, in osteoarthritis of the hip, it's the upper portion of the joint that actually loses its space. Can I zoom in on this anymore? I feel like that's my max right there. So you can see the upper part of the joint has lost its space. There still is medial joint space right there, okay? Osteophyte formation is later. I'd actually go for subchondral sclerosis first. I'm going to change the way we wrote this in the book here. So I would go joint space narrowing, non-uniform. Then I would go subchondral sclerosis, where the bone tries to remodel. That's this whiteness right here where the bone is trying to remodel because of its abnormal stresses. Then you can get subchondral cysts, which are little pockets inside the bone itself. And then we're going to see osteophyte formation as that remodeling continues to express itself out further over top around the acetabulum. And this is an excellent X-ray from a patient here, where you can see a nice big osteophyte going into where the labrum would be as well, pushing all into that space. So key findings again on X-ray: non-uniform joint space loss, subchondral sclerosis, subchondral cysts, and reactive, well, not, what am I going to say? Reactive sclerosis, we already said, but osteophyte formation. Okay, those will be key. Okay, then we also have to have some other special tests that you might do in your office. Well, in your office, a scour test is going to be a win. We have separate videos that you can look. I would also refer you to the orthopedic conditions manual if you wanted, or any of the other texts where you can find that information as well. But scour test needs to be done in stages. First, just move the person's hip around in circumduction with no weight, no downward compression. Then do light compression, see how they tolerate that, and then increase the compression with your body weight over top as much as possible and see if that aggravates. If that is all negative, what I will often do if the person has good balance is do a standing scour test. Now, you probably haven't heard of this or seen this in the literature. It's an adaptation that I made for this assessment. Literally, I'll have the person stand on one leg and then balance and then move their body around, usually holding onto the side of a table or something, and then do the same thing with their own body weight, because chances are they can generate more power that way than I can with my body weight on the side of the table. Laboratory tests are going to usually be within normal limits unless you are trying to rule out another pathology. Now, a couple of the findings here, this elevated erythrocyte sedimentation rate, that's just a general finding for inflammation. So it's not specific. Same thing with C-reactive protein. But if you're trying to rule out rheumatoid factors and other things like that, then laboratory tests might be a little bit more useful for you to rule out those other pathologies. So it's pretty obvious when you see it. X-ray winds up being the confirmatory diagnosis. What are we going to do for treatment? Number one, biopsychosocial support. Make sure that these people have the resources they need and are educated on this condition, right? That's one of our primary jobs as therapists and doctors, is to educate patients on conditions. So you have osteoarthritis. This is a normal age-related change that we see in a lot of the population. Try and normalize it for the patient so they don't have a big fear belief and psychology of chronic pain developing out of this, okay? The other thing to say too is there is a poor correlation between what you see on the X-ray and the level of pain that the person actually has. I have done X-rays where I've seen people who look like they should barely be able to walk, and they're just like, oh no, doc, I just got a little bit of pain in my hip. And other people where the hip looks almost normal and they are almost coming in on crutches. So again, poor correlation. The X-ray doesn't tell you how bad it is from their pain perception. It tells you how bad it is biomechanically from the degeneration of the tissue in the area, but it doesn't tell you their pain. So try and be positive. So acute, it's going to be relative rest. They still want to move it. We know that general joint health for cartilage, we have to move joints around so the synovial fluid gives nutrients to the chondrocytes and all those tissues in there. We also want to look at maybe short-term, and again, short-term use of NSAIDs. You do not want to have a dependency or knockdown inflammation. That might actually be a normal response that should be happening. Mild activity, water aerobics are great. If the person is overweight, especially, get them buoyant in a pool, and then they can move around a little bit. Even in acute cases, even a hot tub is going to be a win for them. And biking is another good choice because it doesn't involve impact trauma into the hip typically. Okay, chronic, finding a balance between relative rest and use of that area. Basic range of motion exercises and strengthening are going to be huge. Weight loss if obese, and I wouldn't see if obese, even if a little bit overweight, try and encourage that weight loss. It'll have more benefits than just their hip. It lowers blood pressure, decreases cardiac event risks, all that stuff is associated with it. Consider heat to decrease pain. I am a big fan of heat. Now, the heat is not going to penetrate down into the hip. It's too far, too deep a tissue for most people. It's so thick and deep in there. But what it is going to do is create an analgesic effect. Some people like cold. I usually find for most people, especially because this is a geriatric patient population, usually pick heat as your choice, especially in the winter or more damp months that you might have around. Okay, massage therapy is going to be fantastic. Early rhythmic techniques where you're actually milking and vibrating through the joint a little bit, giving a little bit of distraction and compression, just again to get that synovial fluid moving and trying to load the joint in different directions, as well as stimulate the joint capsule and areas around there. Long axis traction is huge. People love long axis traction. And here we show a picture of you doing it with actually a strap. We show this in some of our seminars as well. It's easier to do than just grip with your hands. If you use a strap, the strap goes around your waist. And because it does that, it makes it easier for you to go ahead and pull back. Myofascial release is going to be great. Pin and stretch. I'm a big fan of instrument assisted techniques. Even you might consider in really acute stages like lymphatic drainage type techniques, super light to start to build tolerance to touch and movement. Osseous mobs are going to be okay. Definitely working on areas of compensation. So, try and work a little bit more through the low back and the knee and the SI joints if you can, to give them a little bit more mobility there or freedom of movement if possible, or at least just stimulating those areas, right? All of that's going to offer some benefit. What else should we be looking at? Electrotherapies, acupuncture also has benefits as well. If we continue on looking through, diet and botanicals are going to be huge. Again, for weight loss, it's pretty clear in the research, whatever you can do to find sedation earlier and see a decreased caloric intake is going to result in better outcomes for them to lose weight more easily. Now, again, I would refer you, because we make this as a patient handout, grab one of these right up here, have them go ahead and look, go ahead and pick this up. It'll cost you all of $15 to give to your patients nutrition. And there's a ton of stuff on here, evidence-informed nutrition. I give these out to my patients nonstop to promote weight loss and optimal eating, because we know how important it is to overall health that the people are eating correctly. Something else you might see is, well, there are osteoarthritis specific diets potentially. Glucosamine and chondroitin can be out there as well. And of course, just basic good nutrients, A, D, E, C, B6, B12, I'd add to this, zinc, what are you going to say? Pantothenic acid, B5. Okay, there's all kinds of botanicals as well. We got it right behind me. I go to the botanical medicine text and find some good information there. Medications, again, short-term use. Corticosteroid injections, the research is pretty controversial and becoming clearer as time goes on. These are going to knock down the inflammation, but may not be a good long-term solution for this person, okay? You might see supplementation of hyaluronic acid as well, potentially. Even there is some research to support the use of Prolo and PRP therapies injections as well. Surgeries are warranted in extreme cases. The outcomes are actually pretty good. 95% improvement in joint function, but be aware and educate the patient, especially if they're younger, to try and delay as long as possible, because if they're more active, these hip joint replacements tend to not last quite as long, and we see hip joint failures. I can remember when I was working in the Portland Providence ER, one of the first cases I saw was a fine gentleman from the South, and he was in his 70s, and his hip had dislocated something like 15 times because he had had a hip joint replacement. And now the polymer around the acetabulum was getting too loose for the metal, and it would just slide out all the time. One of the neatest feelings as a junior doc, just learning about stuff, to actually be there and feel that hip joint slide back in as I was helping to relocate it. So super cool. All right. Follow up. What are you going to do? Rehab. Consider orthotics or cane. I mean, you might want to look at a leg length evaluation as well, especially following post-surgery, if there could be something that was missed there. Tai Chi and yoga are great for this geriatric patient population. They promote movement, they promote good balance, decreased risk of falls. There's excellent research around both of these. Music therapy can also be beneficial to improve mood overall, and again, incorporate that with the movement. Prevention, weight reduction is foundational, okay? And if it's a laborer, it's like observing or changing how they actually do their jobs, so they're not carrying the weight in the same way, repetitively. So activity modification. There is controversial research around hormone replacement therapy, potentially, but again, cartilaginous injury, it's going to be a slow, poor healer anyway. So just be aware on that. Prognosis often progresses over time. Let the person know that that's a normal thing. Create it as a typical case for this patient. About 22% people over the age of 55 will have hip pain and need a hip joint replacement within 6 years. Now, this stat varies. You can find different stats on different research that you're looking at. But at the end of the day, if it's a more minor, people can improve, especially if you can motivate them for that weight loss. Like a hip joint surgery is no minor surgery. This is a significant trauma to the body. And you want to try and avoid it if you can by using your preventative medicine, right? An ounce of prevention is worth a pound of cure. Makes 100% sense here. But as they get later on into the process and they're going through the hip joint replacement, people are up and moving within 24 hours of this surgery. And again, go and YouTube it. This is no minor surgery. People like to think it's just, oh, they just come in with little saws and are working nice. No, you'll see the surgeons, big hammers working in there. Dislocating the acetabulum is no easy feat with a crowbar, basically tossing it out. So you have to educate your patient ahead of time if they are having the surgery on what the surgery entails and what the recovery time looks like and what we can do to help. There is lots that we can do to help. Even just simple, gentle leg swings like this, usually stabilizing yourself out on the side of a table and then doing the leg swings is going to be a good idea. But that's a distraction movement where you can start to get, again, cartilaginous flow. I would usually have people do this by turning their leg externally or internally, so it doesn't give the same wear pattern that they've had from walking or running or whatever else has caused this for them. You want to change the wear patterns as much as possible, different new exposure to activities. Other ones, you can use a dowel rod where you lift up the inside of the leg, just simple stretches like this. Even hip thrusters are not a bad idea for glute and hamstring strength. Rather than a squat, this is a nice way to do an unloaded lift that'll actually develop relatively the same muscles. And even just simple yoga poses where people are stretching out, just laying down, and you can see the yoga blocks here underneath the knees to give that extra little bit of support. Now, we'll put up another one that shows a bunch of other hip-specific exercises, but just some ideas to entail for that patient on hip osteoarthritis. Fantastic. All right. Thank you very much, and we'll see you in the next video.